Hi, my name is Betsy Meter Brooks, and I'm here today to talk about chronic kidney disease. Kidney disease has a higher prevalence in the United States than the global population. About 14% of adults in the US have chronic kidney disease. 9 in 10 of those adults don't know they have chronic kidney disease, and about one-third of adults with severe chronic kidney disease do not realize they have it. There's a 34% prevalence in people over 65, but only 9% in adults younger than 65. Black people have a prevalence rate of 20%, Asians and Hispanics of 14%, and whites of 12%. A third of people with diabetes and a fifth of people with hypertension may also have CKD. Globally, CKD affects 10% of the world's population. It's more common in women, older people, and those with type 2 diabetes and hypertension. It is increasing as a cause of death due to rising obesity and diabetes rates. This shows the changing prevalence along with staging of CKD. You can see that it is trending upward. I have today a case of a patient. Her name's Sally. She's a 45-year-old white female. She presented to the clinic 3 months after her established care visit when serum creatinine was elevated and A1C was elevated. We didn't have any prior labs due to not having access to healthcare prior to that established care visit. She was acutely ill at that time. Serum creatinine was 1.33 and estimated glomerular filtration rate was 50. It was suspected that it was related to her dehydration, related to her acute illness. And she was asked to come back in today, which she has done. Her A1C at the last visit was 7.9. She was started on metformin at that time. Today she reports that she's feeling well. Complete review of systems was negative, as was the physical exam, except for that she is experiencing right knee pain today. She's a little worried about her lab results that she had drawn right before today's visit because she had an aunt that was on dialysis, and she's a little worried about what CKD might look like. She has a medical history of, recently diagnosed type 2 diabetes, depression, right knee osteoarthritis, and gout. She recently started that metformin 500 twice daily. She's on escitalopram 10 milligrams daily, and she takes ibuprofen for her knee pain 400 milligrams as needed. Blood pressure slightly elevated and BMI of 35. Today, her serum creatinine is 1.24 and her estimated GFR is 55. We also had asked her to get urine albumin creatinine ratio, which was elevated at 56. And her A1C today has come down due to the metformin, likely. It's 6.9%. So let's back up and talk a little bit about the pathophysiology of CKD. It is usually prompted by some sort of insult to the kidney. That can be abnormal kidney development, decreased blood flow to the kidneys due to hypertension or type 2 diabetes, or patients with a history of acute kidney injury. That can be that insult. That insult is then followed by inflammation. Excuse me. The kidney is infiltrated with inflammatory cells that lead to nephron loss. The kidney adapts through hypertrophy and hyperfiltration in the remaining nephrons. And vasoactive hormones, cytokinase, and growth factors are present. The increased pressure and filtration in the nephron leads to remodeling and changes in podocyte function, sclerosis, and damage to the remaining nephrons. This slide shows a little more clearly kind of a flow chart related to how CKD progresses. Notice that the activation of RAS causes a contraction of the glomerular afferent arterioles. That aggravates renal ischemia and therefore reduces glomerular filtration function, and then decreases renal blood flow, which increases the incidence of tubal injury. So you can kind of see that there's this feedback loop early in the disease of increased renin angiotensin system that decreases the single nephron GFR, and then it kind of increases the hyperfiltration, which results in hypertension, and then so that is kind of cycling out of control. So just pointing that out because a key part of this will be decreasing that RAS activation. This slide just kind of shows the far-reaching effects of CKD. Sodium and water imbalance lead to hypertension, increased vascular volume, heart failure, edema. The potassium imbalances lead to hyperkalemia. A decrease in the kidney's ability to eliminate nitrogenous waste leads to uremia, coagulopathies, bleeding. EPRO production is down, which leads to anemia. There's a lack of ability to balance acid bases, so you can get acidosis. And then a lot of problems with vitamin D, calcium, phosphate, those all lead to bone problems. So really wide-reaching effects of this disease in the later stages. And this just kind of highlights those later symptoms that we might see later in the disease: nausea, vomiting, fatigue, weakness, trouble sleeping, oliguria, lower extremity swelling, pruritus, shortness of breath, and difficult to control hypertension. So we don't want our patients to get to those stages 4 and 5 where they really get symptomatic. So it's important that we screen patients who are at risk to prevent that progression of the disease. That means screening patients with high blood pressure, diabetes, cardiovascular history, family history of CKD, any personal history of an acute kidney injury, exposure to environmental or occupational nephrotoxins, and then having other conditions that might impact kidney function, and then also poor access to health. Remember, we're never going to be aware of something like an AKI or diabetes if they, weren't seen by a medical professional at that time. So something to keep in mind there. How to screen. So once we have identified risk factors, then we kind of move through our algorithm here to screen. That means testing blood glucose, spot urine, blood pressure, and getting that good family history, and then measuring kidney function. This is usually done, in my experience, with a creatinine used to calculate estimated GFR, and then also making sure to order that albumin creatinine ratio urine lab to kind of also look for kidney injury in addition to the kidney function tests. So then we'll talk about if we, get a positive screen, how should we manage that in the primary care setting? So I used the KDIGO 2024 clinical practice guidelines, focusing on the top 10 takeaways for primary care providers. First, recognizing that this is going to have to be a multifaceted approach. There are lots of moving parts with CKD, so we want to be talking to them about treatment to reduce complications. That means lifestyle, exercise, diets, and medications. Diet should be encouraging more plant-based foods in their diet, lower animal-based foods, lower consumption of ultra-processed foods. Let's see, I don't think there's anything here about sodium in particular, but we will want to recommend a low sodium diet too. So not really unlike a lot of the diet recommendations that we make for a lot of disease processes. We also want to have a really tight blood pressure control while keeping in mind our patients as a whole person. So probably not super tight blood control in people that are at higher risk of falls or at the end of their life. But for this patient, at the very, otherwise somewhat healthy person, would want to try to get those numbers down closer to the under 120 and under 80 diastolic. And then for medications, we want to be prescribing medications that delay progression of CKD. And that means RASI and SGLT2s. So RASIs encompass both ACEs and ARBs. Those are both RAS system inhibitors. And then SGLT2, those specific medications used in diabetes. Third, and this was something brand new to me, is to use a cardiovascular risk calculator that includes a way to measure or a way to incorporate CKD. So that means using something, probably the strongest one is the Prevent Online Calculator. This is a new way to calculate CVD risk created by the American Heart Association, available for free on their website or on MD-Calc. And just have a little screenshot of it. It's similar to other calculators, but it does include this estimated GFR, presence of diabetes, smoking, and body mass. So that's going to be does create a much different 10-year ASCVD risk scores. So that is the recommendation from KDIGO, to be using something like this. When looking at estimated GFR, be aware of what goes into that. I have the actual calculation on here. This is what the EPIC that I uses. The GFR is based on creatinine, and it's the 2021 formula. This formula does not include race, as previous ones had. And there are also GFRs based on cystatin. I have not come across those. I imagine those are probably used more in specialty care, or it might be a regional difference. So this slide really highlights that when you're starting those RAS inhibitors or SGLT2 inhibitors, you can expect a change in GFR. So this is more with ACEs and ARBs. So you're going to be monitoring that serum creatinine and potassium right off the bat as soon as you start that dose. And then you're going to be increasing into the maximally tolerated dose. So that means having these patients back in clinic quite a bit. If we're seeing things like a really big jump in creatinine, we're going to be pulling back, considering diuretics. So lots of labs for these patients, lots of encounters with the healthcare system. We also need to perform a thorough medication review to make sure that there are no other drugs that are potentially nephrotoxic, and then remembering to use equations, so renal dosings for drugs, using that eGFR. And then knowing that these patients are sometimes at risk of having medications discontinued when they're acutely ill because of things like increases in creatinine. So we really want to make sure that we're doing a thorough med rec each time we encounter this patient, especially after hospitalizations or for patients who might have care in outside organizations, other providers ordering things or discontinuing things. Okay, and the last treatment recommendation here is knowing when to refer to a kidney specialist. This includes, wanting to find out the cause of the CKD when it's not well known. When your GFR dips below 30, definitely want to be referring, or any kind of significant decline in GFR that happens abruptly, or between 3 and 5% risk of kidney transplant in the next 5 years. So in order to calculate that, I went to kidneyfailurerisk.com. You can just put in their GFR and their albumin creatinine ratio to get their risk of needing a kidney replacement the next 5 years. Easy to do. Okay, back to our case. We now know that we can use this chart to categorize Sally. She is in a category A2 for albuminuria. And then with a GFR of 55, she's in stage G3A based on her GFR. That puts her at a moderately increased risk. So back to this chart here to kind of look at moving on to the treatment part of this chart, we're going to be looking at lifestyle modifications, close lab monitoring, and then medications to treat what the suspected causes. That would be her uncontrolled blood pressure and type 2 diabetes, and then medications that also slow kidney disease. Those would be the SGLT2 and then the RAS inhibitors. And then also considering if she needs a medication to decrease her risk of CVD. So fortunately, Sally was really energized to tackle this new diagnosis, and she wanted to do everything possible right at that visit. So we kind of rolled out everything. Some patients may be more reluctant about starting a lot of new medications, would kind of need to take it more slowly. Her being an otherwise healthy patient, she and her provider agreed on starting some new medications. We started the long-acting ARB, olmesartan, for her blood pressure, dapagliflozin, her SGLT2, for her diabetes. On that PREVENT score, she did have over a 10% risk, so we started at atorvastatin. And then for her right knee osteoarthritis pain management, we looked at that as another possible cause of her decreased eGFR. So wanting her to try, instead of the NSAID that she's been using daily, switching over to Tylenol and then using a topical NSAID. But also wanting to take a whole patient approach and knowing that if she still needs to reach for that NSAID, sometimes we need to, have that conversation that she might be able to use it sparingly to maintain her quality of life related to pain. And we wanted to follow up in 1 month. We're going to be getting labs, rechecking for her potassium levels, basically getting another CMP potassium, and then looking for jumps in that serum creatinine. Takeaway from this case is that a PCP should be aware of when to screen for CKD and then how to follow up on a patient that we note that they have an elevated serum creatinine or any albuminuria. Many patients are living with CKD and are not aware of it. We've learned that we know that through the statistics, and then this case is a good kind of example of that. The provider needs to be aware of choosing those renoprotective medications for diabetes and hypertension, reaching for those first. We need to be aware of using that PREVENT calculator. Again, if we had used the old AHA CVD calculator, she would not have had a risk of over 10%, and we wouldn't have started her on a statin. And the PCP will be using the labs at follow-up to help guide increases in her medications or a decision about whether she needs to be referred to a nephrologist. So overall conclusion, just remember that the care of patients with CKD is multifaceted. There are many moving parts, and we need to be focusing on those things that are most important to the patient, given that their goals and their comorbidities. We're really going to have to be seeing them frequently for labs and kind of tweaking medications. We can kind of take advantage of that by remembering that we can be incorporating some patient education into each visit. So every time we get an opportunity to come in contact with the patient, it's an opportunity for education. And then it's really important that as PCPs, we're able to recognize when to refer to a specialist and also when we're able to manage in the primary care setting. Not all patients diagnosed with CKD need to immediately be referred to nephrology. Thank you for listening. Have a few resources on here, all those that I mentioned, the PREVENT calculator, the official guidelines, a kind of more The guidelines suite has a lot of key takeaways for evaluation and management. And then that kidney risk calculator to also help inform the decision of when to refer to nephrology. And then these are the references for those four that were used in the making of this. Thanks.